So, Assalamualaikum and very good morning to everybody. My name is Muhammad Wafi bin Muhammad. I am one of the occupational therapists from Faculty of Health Sciences. Currently, I'm working with occupational therapy program, and we are very fortunate to have our own clinic for practice. Okay, so this morning I'm going to share with you the occupational therapy practice in visual rehabilitation. So as for myself, I've been involving with handling patients from visual rehab and blindness for the past 8 years. I'm starting as one of the assistant to the senior lecturer. I think most of you know him if I mention his name. He is Encik Nozailan. Okay, he is a very dear lecturer and a lot of input for us to develop our curriculum and specialty in visual rehabilitation is from him. At first, we focus on orientation and mobility. So after about 3 years, we start to take a patient. We are getting referred from almost from all over Malaysia, right? And after about 5 years, we look into expanding from providing only orientation and mobility towards visual rehabilitation. So this is my sharing with you. So if there is any comment, okay, then you can share with me later on. Right. So our outline of presentation today is, of course, I'm going to talk about what is occupational therapy, very brief, inshallah. And we will go into occupational therapy in visual rehabilitation, or the short form is OT. And then we will look into treatment modalities and later on intervention strategies. Okay. So basically, the whole lecture here is to give you an overview of what is occupational therapy is all about, where do we work, and what is our subspecialty or services that we provided. And of course, visual rehabilitation is one of it. All right, so occupational therapy by definition. All right, so basically for us to understand, occupational therapy is a profession that
Joy, how labo, how mother, kiam pisin dah.
Hi. Sorry, tak dengar. Tak dengar. Right. So actually, occupational therapy is a profession under umbrella of rehabilitation, which is usually consists of clinical psychologists, physiotherapists, speech therapists, and others. Right. So the way we work is that we are looking into the occupation of our patient, covering activities of daily living, work, and leisure. What is the differentiate us compared to physiotherapists? Because this physio is one of the profession under rehabilitation that is usually being compared with us. So I give you a very clear example. Occupational therapy is a profession that when we treat patient, we prescribe activity, therapeutic activity. So for example, if someone involved in a motor vehicle accident, okay, he maybe got a fracture. So this patient, when go to the hospital, okay, the doctor will do all the operation and give him a prescription of medication. The nurse will do all the bandages, cleaning the wound, and so on. This patient, if let's say the injury affected his functional ability, okay, then the doctor usually will refer this patient to us. So what we do? So actually, we will provide a functional activity as part of intervention. For physio, usually they will do exercises and they will prescribe maybe a musculoskeletal exercise program, something like that. So occupational therapy, in short, is a profession that look into the functional and well-being of a patient. And how we treat our patient? We treat by prescribing activity, therapeutic activity. So that is the unique thing about us. Okay, areas of occupation, right? So there are actually quite a number of framework in terms of area of occupation. So I'm going to go for 3 areas of occupation, which is very basic, and it reflects the role of occupational therapists. So the first one is ADS, which is stand for activities of daily living. So everything that you do, okay, when you wake up in the morning until you sleep, even sleep itself is considered as activities of daily living. All right. So if let's say you are being diagnosed with some health issue, and it interfere your function in activities of daily living, okay, we are the profession that you should come and talk to in terms of how we're going to plan your rehabilitation activity, something like that, right? So we also look into work, okay, anything got to do with employment, maintaining and performing job, even preparing for retirement, all right? Okay, so this is the areas that occupational therapy usually work to. Okay, for example, the last 3 years ago, I have been referred with patient. Her age is 29 years old. She's being diagnosed with diabetes mellitus type 2, which is result for diabetic retinopathy. Okay, one of her eyes, the left eye, is out of action, meaning cannot use anymore. Okay, so the one that function is the right eye. So what we do, okay, after we look into her activities of daily living, okay, because she is 29 years old and she is a graduate student. Okay, so we look into matching his academic qualification and working opportunities. Okay, so in conjunction with that, we managed to find a place for her at Maiden, if I'm not mistaken, Maiden, forgot lah, Maiden Selayang. Okay, so because she is staying at Gombak, okay, so part of my job in visual rehabilitation, okay, towards areas of occupation of work is to look into how for her from his home at Gombak to go to work at Maiden Selayang. So we work on pathway in terms of the starting landmark, okay, and then the bus stop, okay, what kind of bus or bus number that she need to take to go to the Maidin Selayang. Okay, right. So not only that, at work, okay, because of her eye status, okay, we have to identify landmark for her to do scanning activity so that she can work and she can walk independently. Okay, sometimes she will be using a white cane, otherwise using the scanning technique and marking of landmark. Okay, usually we will identify the safest route, and she used to use that particular route to get into the workplace, right? Okay, other than that, we also look into a leisure. Leisure basically things that you do during your free time. Sometimes people refer this as a hobby. Okay, so in our cycle of life, or our if we look into holistic approach of human being, so you have parts that you're doing your activities of daily living, okay, to earn for yourself, right? You go to work, okay, and of course after tired spending your time at work and so on, you need to have leisure. So for leisure, what we do actually, we will match the performance and the requirement of patient. Okay, so we look into financial aspect, physical aspect, and then usually we will prescribe what kind of leisure that most suited with our patient. Okay, so it is a very interesting profession because compared to others, ours is quite subjective. Okay, our treatment is quite subjective because it is a way of you to do your job, or the way for you to do your work, something like that, right? Okay, in terms of services, right? So basically, when we are attending a patient, what we're going to do, we do individualized evaluation, right? So there are various type of assessment, looking into areas for ADLs, for the work and leisure. And sometimes in ADL, you have to break down into musculoskeletal assessment, or nerve assessment, or maybe cognitive assessment. Okay, there are lots, right? Then, of course, after we identify the problem based on the assessment, we will customize intervention. This is part that I'm telling you, that we prescribe activity, because most of our intervention is activity, right? Okay, and later on, right, and of course, we match our intervention together with the goals of the patient. Okay, so what is the target for the patient? Sometimes in setting up the intervention program, we need to match the goals, whether it is based on the assessment or the condition of the patient, or the patient needs itself. Because sometimes some of the patient, maybe they are in a situation, what we call it, they do not accept their condition. They do not accept their condition, and they expect more. Okay, so it is our responsibility in customizing the intervention to make it rationalized towards patient. Otherwise, if let's say the patient put the target very high, something like that, but his ability or functional capacity is is not par, then he's going to be maybe in a set stage or something like that. Okay, so that is part of the responsibility. Okay, usually we will discuss and we try to match the goal. Okay, and we separate, we divide it into two categories, whether it is we start with the short-term goal, and we also establish what is the long-term goal, right? So for example, if let's say I have a patient referred to me with a visual condition or blindness, something like that, after some of assessment, I will look into what is the status of the visual function of the patient. So if let's say the visual function cannot meet the demand of the client, okay, we will look into what is that can be achieved in the short-term time. For example, things that we can target in terms of treatment, something like orientation training. Okay, so if let's say patient target she or he wants to get back to working life. Okay, so usually we will sit down and discuss based on assessment. Okay, we set the short-term goal. Maybe we will focus on orientation training. Okay, ADL training, something like that. Okay, so the long-term goal is to make her to be able to go back to the work. So what is the long-term goal? Whereas orientation, ADL training is for the short-term goal, right? Okay. Okay, so areas of practice, right? So being an occupational therapy in Malaysia, then in Malaysia, actually the backbone of the health services is under Ministry of Health. So most of occupational therapists, after graduated from university, they will work at the government hospital. Otherwise, they have option to work and go at the private hospital, private practice. Okay, they can take up master or certificate and become a lecturers. Okay, some of my students, they are very creative. They get certain certification specialties, and after 5 years, they open their services. Okay, so I know 2 or 3 of them maybe right now a millionaire because they have center all around Malaysia. But I'm still here. I'm staying with UKM, inshallah. All right. So in terms of areas of practice, again, we look into acute hospital settings, okay, mental health, all right, development in pediatrics, okay. Hand and upper limb is one of the most interesting subspecialty in occupational therapy services. Okay, before I joined UKM, I was at Kuliah of Medicine under International Islamic University at Kuantan, and my department happened to be the Department of Hand and Microsurgery. So every month we get quite a number of reference. Okay, we have a patient that having lost their fingers, their hands, sometimes their forearm or their arms are cut off because of motor vehicle accident. So our team will do the surgery, the doctors of course, but then later on they will refer to us for the functional training of the hand. So it is very interesting. Okay, various kind of hand and micro surgery condition. Okay, so there are lots of subspecialty in OT, right? And one of the new chapter or maybe a new beginning. Not that new beginning is visual rehabilitation. Okay, as I mentioned before, we from Occupational Therapy Program of UKM, we started with orientation and mobility 10 years ago. Then later on, after 4 to 5 years, we evolved to visual rehabilitation. And right now, we are the only clinic under the higher education university that providing both of these services. So far, I do not hear any other institution that offering this. So it's not a proud moment, but it is a responsibility that we have to shoulder. Because before I started, because my interest is actually in hand and microsurgery, because it's very objective, you know, cut off hand, the surgeon will do the operation, okay, then you do the therapy and so on and functional training, and you can start to see patient be able to use their hand, okay. Otherwise, in orientation and mobility and visual rehab, the challenge is sometimes greater than that, because when we have when we get a referral, sometimes we have to settle down patient in terms of emotion, psychological aspect. You know, sometimes I have a patient age of 60 years old diagnosed with macular detachment. For the first 6 sessions out of 20 sessions, whatever she come to the department, she will cry, okay, and you know, my husband do not love me, my daughter do not understand me, okay, I am alone, why Allah give me like this. So you have to be sort of like a consultant first. You have to being a counselor, not consultant, counselor. You have to calm her down, okay, make her realize what is actually happened, and actually everybody is supporting her. But because of the depression, 60 years old, and suddenly you cannot function because of your eyes. So it is very sad. This is very sad. So we are happy to provide the opportunity to do the rehabilitation, and we are still learning. It is actually, there's long way to go, okay, and there's lots of things to do, right? Okay, so visual function. All right, so this is just a bit of what should I say? A bit of explanation for the participant to understand how we as OT view the visual function. Okay, for us it is a primary sensory system, okay, used to acquire information about the environment. So 80 to 90% of learning which occur through visual channel, okay. So basically, to put into easier perspective, we evolve, we go to school, we go to work, we'll be able to do all activities of daily living, so on, so forth, and so called, is because of our visual function, meaning our eye functioning accordingly, okay. We do not have any sickness or any condition that might deteriorate the level of visual function, okay. Sometimes we take it for granted, okay. So please look after our eyes, your eyes, my eyes, okay. Maybe we do the checkup, something like that, okay, for every 3 or 6 months, right? Because most of the things that we achieve, right, in our years of living is because of our visual function perform very well, okay. For example, if you go you get into the room, okay, because your eye is very okay, it work normal, okay. So whenever you get into the rooms, all right, you can see everything clearly, okay, 180 degree, okay, from right to left, you can see clearly, okay. But if let's say you have, and sometimes we ignore the beauty of the system, you know. I mean, when you get into the room, okay, basically, if we look into a mathematical approach, the system calculate everything, okay, the range, the visual equity, the depth, you know, the variation of colors, so that you can see the wall is the furniture is not actually together with the wall. It is in a different position, you know. So that is the beauty of our visual function, if it is function well. Okay, otherwise, then we might go under low vision condition or blindness, right? So take care of our eyes, right? Right, so it is a dominant sensory system, okay? It of course, because we can see, you can see, I can see, so anything happen in front of you, you can anticipate, okay, what's going on, and you can plan, okay. It drives decision making, okay. If let's say you are driving a car and suddenly maybe elephant cross the road, so whether you want to go straight or stop first, okay. So you can make fast decision. Sorry, I'm very I'm using a kind of sarcastic example. Okay, of course, it interpret social interaction, because you can see because we can see people around us. Okay, we have issue in terms of social interaction. Long time ago, we have a referral patient with hemianopia. Hemianopia is condition whereby the left side or the right side of the eye you cannot see. You do not have vision. Okay, so for this patient, the vision is on the right side. So in Malaysia, of course, we have kenduri, you know, we have Chinese New Year, we have lots of parties, okay? So when my patient went into this social gathering, okay, some of his friends told him that he is arrogant and ignorance, because when they approach him, okay, he do not say hi, no salam or something like that, okay. So what we do is we prescribe the training, what we call it scanning, okay. We use scanning as part of the intervention, okay. So we usually for the social activities or social interaction which is involve many people, okay, I will always ask him to find a landmark whereby it will cover his left side, so that he can maximize the range that provided by the right side of the eyes, so that people actually, when approaching him, people do not approach through his blind side, okay, approach through his vision that still exists with him. Okay, and of course, supplies speed in information processing, okay. If let's say you are in the market or in a situation whereby your child is falling down, of course you look into that, okay. I don't split second we will make a decision whether we to grab or to save our child, okay. There's no such thing as, oh, my child is falling down, oh wait, I have to think, okay. What is the distance, how many seconds I should respond, okay. So the process is not being like that, okay, because you have a good visual function. Anything happen, then the speed of information that you get, it being processed, and you act accordingly, okay. Of course, it dictates motor action, sometimes in emergency, all right, millisecond of action, right, whether to help people, or if let's say you are driving a car, to brake, if let's say you see somebody try to hit your son or your daughter, okay, then you can protect yourself. Okay, early warning system for postural control, right? So this is for the sometimes because of the eyes also influence the balance and the proprioception of the body. Okay, if they have problems in this particular area, okay, then the visual function will act as a warning system, okay, for the postural control, to regain back a control. Okay. Okay, so next. So why OT in visual rehabilitation? Right. So because we are the profession that look into occupational performance. So basically is to enhance occupational performance for specific activities of daily living by training skills that are dependent or residual vision as reading and writing. So meaning that we analyze how people perform. We break down the task. For example, you if I give you an example of in activities of daily living. Okay, you want to patient want to eat, right? Right. So maybe because of her condition, she cannot eat normally. Normal people, okay, bring the nasi and so on and start to eating, clean the plate, okay, within 10 minutes, something like that. So for us, for patient like this, we will look into their occupational performance, and then we break down the process, and we train from orientation, and then we use clock reference until patients are able to come back into certain level of performance. All right. Of course, one of our specialty, because we look into how to maximize function of our patient. Okay, some treatment when we prescribe using the actual function of the patient itself. But some of the treatment require home modification or some additional equipment in her to improve his performance in workplace or at home or school, okay, and so on. So we have a specific environmental assessment. This is we do during a home visit. Okay, we look into for visual rehab. Usually we look into glare, we look into lighting, we look into arrangement of the furniture. Okay, whether it's going to be hazard towards patient. We look into a fall risk, something like that. Okay, right. So evaluation, right? So evaluation. Basically, when we receive a referral, okay, we will do the evaluation. Okay, so part of the information that we look into is the pre and post of level of function. Okay, so before being diagnosed, what is the functional level? Okay, after being diagnosed, what is the functional level? Current functional level within the diagnosis. Okay, of course we look into ADL, work and productive activities. All right, and we will do a written assessment. Okay, contrast test and lighting. This usually we will work with optometrists because they are the professional person that can look into this thoroughly. Okay, so usually this one we will collaborate with optometrists. Right. Okay. Central vision assessment. Okay. Some of the central vision assessment it can be done by us. Usually we use BIVABA. BIVABA is a brain injury assessment. All right, but it covers lots of visual function portion, so it can be used. But that one is to look into the visual function that's still left towards patient. Okay, not into detail or not into prescribing the condition itself. No, that one we still require the assessment from optometrist or ophthalmologist. Okay. Physical status, of course, cognitive status. All right. So cognitive status, usually we use MOCA, Montreal Cognitive Assessment for blind. Cognitive play a big role in rehabilitating patient with visual problems. Right. Okay. Cognitive play a big role. Right. So based on my experience, sometimes when you get a referral with a multiple condition, so it's quite tricky actually. Okay. Okay, plan of care. Usually we will develop with patient and family members. Okay, again to determine the goals and outcome. So it is in line with what we're going to achieve, right? We have short term, okay, and we have long term goal, okay, updated monthly, and long term is for the functional outcome, right? Okay, so we will go into intervention, right? So if you can look into the picture at the bridge, okay, that is me. As is that time I'm doing orientation and mobility training somewhere at Gombak. Okay, somewhere at Gombak. This is around 2007, something like that, right? And of course, we have to eat and drinks or having lunch, full set of lunch using blindfold for simulation. So our grandmaster by this time is Encik Nozailan. He is very good in terms of pressing us to get the certain skills in orientation and mobility. Right, so treatment modalities. Okay, this is basically the big group of treatment modalities that we provide to the patient. Okay, prescription of eyewear, we do not prescribe. Optometrists will prescribe. Okay, but what we do is we will teach the patient, okay, how to use the eyewear and how to assimilate that into activities of daily living. Because sometimes patient the prescription is very good, but when because he or she may be in a stage of looking into how to being functional in certain activities, so sometimes they put aside. So we will look into the training. Okay, prescription is done by optometrists. Okay, optical devices, right? More or less it's like the prescription itself is being diagnosed sometimes together with the opinion of the optometrist and occupational therapist. Okay, for example, optical devices, devices like Pico Pico is a handheld electronic magnifier. Okay, so there are quite a number of models. Okay, so basically the prescription will be done by optometrist, but the training or the functional side is done by us. So sometimes we will discuss together. I give my input. Here, our optometrist will give their input so that we can buy or we can get the patient the best model suit their needs. Right? Electronic aids is a lot. Electronic aids item like CCTV, Pico is part of the electronic braille, something like that. Okay, adaptive computer software. This one we collaborate with Malaysian Association for Blind. Okay, because you have to master the software, and the software itself for me is quite complicated. Okay, you have JAWS, you have nanotech, something like that, you know. So for that, when they use computer or they use the smartphone, then the software can read the screen and give a feedback lah. Okay, right? Okay, glare control. All right, this is involve either home modification or maybe lighting. All right, counseling and education. Of course, we do lots of counseling. Okay, especially patient. The patient itself sometimes the younger patient is not that difficult. It's not that difficult, but the parents, that's problem. Okay, because sometimes they refuse to accept the stage of the condition of their children. Okay, we have a patient that being actually blind for the past maybe 4 months, something like that, but the father is refused to send this particular teenagers to certain school. In Malaysia, we have for secondary and primary school, we are very fortunate. We have a few school which is dedicated to cater low vision and blind student. Okay, so congratulate Ministry of Education, okay, for their commitment. All right, independent living aids. Okay, mental health intervention. All right, so I have come across a student with a mental health issue. Okay, so what happened is this fellow teenagers, okay, he will pee inside his friend. They live in a hostel, so they have what you call, it's not a cardboard, what you call that, when they put their clothing, something like that. So they went and pee over inside their friend's closet. All right, and being denied. Okay, some of it refused to go to the toilet at night to do their business lah. So what they do, okay, they do it inside the bucket, and then they put the bucket inside the closet. Okay, sometimes they do it on the mat. All right, so it's very frustrating for the warden. So that is part of a situation that we intervene as occupational therapy. Orientation and mobility, of course, we do orientation and mobility training. As for myself, I have experience doing it for school students, okay, for the teenagers. Okay, we also doing it for adult patient. Driving rehabilitation. Driving rehabilitation is actually in conjunction with the Department of Road and Transport, the JPJ. Okay, so usually the doctors will give the prescription whether the patient is available, whether the vision is still available, or I mean can that particular can drive his car on the road. Okay, then we will do the simulation. We will do the cognitive assessment. We will do the simulation assessment and training, and later on we will pass over to the JPG or Road Transport Department, because they are actually the one that will issue the license, the tax, and so on. Okay. All right. So intervention strategies. Okay, intervention strategies. We have 7 strategies. Okay, so strategy number 1, we enhance contrast. Okay, most people with a visual impairment, they see better if objects are black and white. So if, let's say, we look into activities of daily living or home modification, we will look into this part so that the contrast is real, all right? Okay, so we enhance the contrast, all right? So for activities of daily living, sometimes if, let's say, they already have a good setup, a good table, all right? So we will look into the color of the utensil or the cup, something like that, and we find something that contradict or contrast, so that the item that they use is appear strongly. Okay, so if we look into this picture, see, so the medication is white color, the table may be also white color. So patient with maybe cataract or macular degeneration, something like that. Okay, maybe this is, they cannot see that very clearly because it's very difficult to identify the background. Okay, so we put this is maybe some a plate or anything that to enhance the contrast, then we can see the medication. Patient can see the medication. All right. So for the stairs, usually we use this yellow strip. We recommend to use this because it's easier for the visual impairment patient to look into it. Okay, contrast again. Okay, this is for the home appliance, right? Okay, next one is illumination. Okay, illumination basically for patient with cataract or patient with low vision. Okay, what we do is we enhance good lighting. That's all. Okay, maybe additional lighting at the reading table or at the tabletop where she or he may be doing his house chores or cutting vegetables, something like that. So it's very focused. Okay, and easier for the client to work with a good lighting. Okay, glare, right? So right, glare is a bright dazzling light. So glare is actually really uncomfortable, right? And it is make it very difficult to see properly, especially for us as normal people when we drive at night. Okay, when a car come from front and they give a high beam, sometimes then we experience glare. Okay, but for the people, for the patient with visual impairment, okay, this is very serious sometimes because they cannot see properly, of course, and it causes the eye fatigue. Right. So what we do, right? We do not prescribe that. Okay, the optometrist will prescribe this glare control anti-glare lens. So what we do is we customize the session in terms of how the patient should use their glare control glasses or lenses, right? Or sometimes we will integrate the usage of the lens into activities of daily living. That is our part, right? But of course, in our assessment, there are questions about glare. So if let's say it is missed by optometrists, then we can refer back. We can always refer back, okay, for them to do for the investigation. Right. So this is glare control. Okay, and this is part of a home modification. Right. So the light is very bright, and it reflected from the surface. So either we use a different lamp or we just apply a filter. Sometimes you can buy what you call it a tinted sticker. You just put there and it reduces a lot. Okay. Of course, the use of sound. All right, so this is part of the sensor that usually we put at the mug so that it can measure when you pour water inside the glasses or mug. Okay, so when we listen to the sound, that means it nearly at the top of the mug. Okay. The device is liquid level indicator. Okay, this one is talking, measuring jug. So we pour in water, then it will tell you how much the water is inside the jug. Okay, so today is now is quite advancing. Last time when I teach them, okay, we do the intervention. We used to measure with hand. Okay, there are certain technique. Okay. Okay, magnification. All right. We use a magnifier. So relative distance magnification is basically you find a suitable magnifier and you put at the object. You do not move towards object. Okay, but what happens is the magnifier will enhance the size of the object. This, of course, in conjunction with the prescription from optometrists. So prescribed by optometrists, but we as OT will train a patient in his daily living task. Okay. Relative size magnification. This is very easy. You increase the size, make it a big, bright, bold. Okay. The other one is angular magnification. Angular magnification is a kind of system that they have a video, okay, and they will look into your face or any object that you want to focus, and it transmit the object into a bigger screen. Then you can see. So, for example, this patient, okay, the image is transmit through the camera, and it is enhanced using the monitor, so she can see where is the lip. Right. Okay, learn to use eyes and tools more effectively. Okay, visual scanning training, eccentric viewing. Okay, so this is part that we do thoroughly with patient. Not so much for the teenagers, for the school patient, but I use to train visual scanning for adults, people at 40s, 50s, 60s with diagnosis of visual impairment. Okay. So eccentric training, okay, also part of it. All right, so eccentric training is usually the central vision is they have what I call it scotoma, something like that. So you cannot see at the central vision. So what you do is you identify the range of the central vision, and then we usually tilt our head either to the right or to the left to find additional angle. Okay, then later on when we establish the value, it is easier for the patient to use it in their daily living life. But actually, it is one also good if, let's say, you have somebody that very annoying. So you can talk to him, but you do not see his face because the center vision is being blocked. Okay, that is a bad joke actually. Right. All right. So that's all. Thank you. We go to next. Can we have a 5-minute break?
Okay.
Okay, so this is the second topics that I'm going to cover: activities of daily living, applied, and challenges. Right. So our outline is actually we're going to look into a bit deeper in activities of daily living, and we will go into assessment very briefly, and then orientation for activities of daily living, and of course activities daily living simulation. So I have provided quite a number of a video for the sharing, so that maybe that we can you can have understanding on how we do it in our clinic. Okay. There are situations when we receive a referral, and when we do our assessment, and when we start to do the intervention, we have to sometimes we have to go to very basics. Okay, for the patient to be for us to be able to bring out the potential performance of the client or the patient. Right. So we will look into what is actually happened in showering, toileting, and toilet hygiene. We only discuss briefly. Okay, I will do a lot in dressing, feeding, and functional mobility. Okay, out of 1, 2, 3, out of these 6 sub areas, okay, 4 are the one that I have experienced most lah. Showering, dressing, especially because we have lots of issue regarding on how to manage the wardrobe, looking into the cleanliness of the clothing and so on, feeding, and of course functional mobility. All right. Okay, so for the assessment, this is the main 4 that we usually use. Okay, MOCA test blind is to measure the cognitive level of the blind patient or low vision patient. Okay, so I recommended you use this one. It can be downloaded. It's free. Usually it comes with the instruction and on how to do the scoring and so on. Okay, very nice cognitive assessment for blind patient. And then usually we use a visual questionnaire, VFQ25. All right, this one also available online. All right, this is for the functional well-being. All right, and for the visual function of the patient. All right. The third one, but basically this is the main one lah, BVABA. So BVABA is the brain injury visual assessment battery for adult. All right. So the designer of this assessment is Mary Warren. That is her picture. So basically, it covers basic visual function assessment and also visual attention assessment, right? So based on BVABA, we can identify what level of the function of the eye. Okay, either it's visual acuity or contrast sensitivity or the visual field or the oculomotor function. Okay, so we will look into it, right? And of course, we also use activities of daily living assessment and treatment plan. Okay, this is also this is a 4 assessment that we use in assessing our patient and summarizing the visual function of the client. Right. So component of evaluation, we will look into occupational profile, the case history. Case history usually include the medical the demographic data, the medical history, current medical status, and then we look into evaluation of visual factors, environmental evaluation if needed, okay, and then evaluation of occupational performance. There are other assessment actually other than that four, but that 4 is usually the common one. Okay, sometimes we may need to use add-on modified Barton index, that is MBI, but that one is usually done by occupational therapists. Okay, so in the case history, we will focus on vision history, okay, health history, because always at all time these two complement each other. Okay, pre-morbid occupational history, client needs and goals. This is actually the target to achieve after a certain period of rehabilitation, to be able maybe to function, to be able to do activities, maybe cooking or something like that, or maybe to be able to read brain, or sometimes driving. It can be anything. So that's why we will look. We will sit down with patient and look into it, and we have to bring the patient to realism, right? Of course, we look into psychosocial and cognitive issue. Psychosocial, sometimes part of it is the financial issue, because if you have a patient with not very good financial background, it's limit his potential to show up to the clinic, because you have to pay for the transportation. Maybe sometimes you have to pay for Grab, something like that. We have to look into it. We have a patient that from Sarawak, because of her dedication, we arranged for 1 week intervention session. We even not sponsor, but we ask for a discount for accommodation. So we managed to cap 1 week. So we do it every morning and noon, very extensive session. And Alhamdulillah, this patient eventually understand how to function, how to do mobility, how to manage himself, okay, at the basic level, okay, because he is actually at the near suicide. He decided to choose a suicidal pathway, but Alhamdulillah, I'm very fortunate we are managed to look into it. Okay. Okay, so orientation for ADL. Right. So basically, this is the definition of orientation. Okay, I will read out very briefly. It is a process of using senses to establish position and relation to all other significant objects in one environment. So in a simple way, is for you to use or for the patient to use whatever senses that still left inside him, amplify it, maximize it, so that he can identify what is around him, right? So we have a situation when when I go to one of the special school. Okay, so the headmasters told me that because of some of the students being blind from birth, so they develop a very sensitive listening and smelling senses. Okay, so they can identify the sound of walking pace, okay, of headmaster, of disciplinary teacher, or their class teacher. So if it is a headmaster, everybody quiet. If it is a class teacher, they can go hoo-ha, something like that. No worries, because this is a good teacher. Headmaster, no. Okay. Some of them also develop a trait that they can identify the perfume. So the discipline teacher, other than different sound of walking pace, also using different type of perfume. So when this kind of smell come around, then this is a disciplinary teacher. So everybody keep quiet, stay at your table, something like that. Okay. So this is also we explain to the patient that sometimes when Allah Ta'ala take out one senses, there are still some more that still with us. So we just need to find on how to utilize it, because for adults it's very challenging, right? Right. So general principle of orientation. Okay. Remember 2W, 1H. Where am I? What is my objective? How do I get there? Or how do I do it? Okay, especially in activities of daily living, because you have to identify basically where am I, what is I'm going to do, what is my objective, how what is I want to achieve, whether to maybe cook simple dishes or something like that. And how do I get there? Basically meaning how am I going to do it? Okay, to prepare the maybe meals, or to make a simple sandwich or something like that, right? Okay, orientation basic 4. This is actually what we developed after 5 years of experience in receiving a referral and how to start with. Because if you look into the textbook, you look into vision deficit, a guide for occupational therapies. If you look into orientation and mobility from 1957, you look into Lil Deborah, the new norms of framework in visual rehabilitation. They mention about orientation and mobility, but they do not mention how to start with, how to introduce orientation in a very fundamental and basic way, so that the patient or the client understand where to begin with. Okay, so I name this as a basic 4. It is actually to establish one basic. It is basically to identify a landmark, and you start with identifying one landmark. Okay, and then the basic 4 orientation is the front, back, right, and left. Okay, so this is the video. So in this video, I'm going to demonstrate the basic 4 of orientation, which consists of front, back, left, and right. Starting from sitting position. So Ms. Afia, please show me where is your front. Okay, show me your back, or back direction. Okay, next is right direction. Right direction. You may bring down your hand. Okay. Left direction. Okay, now you're going to do it all together. Okay, so basically at the middle of the part, my my subject is quite confused lah. Okay, so basically when I mention right, it's supposed to point to the right. If it's mentioned left, it's supposed to point to the left, and so on. Right, we continue.
Besar untuk button.
Back, right,
Apa sayang?
left. So in this video, so we have done basic 4 from sitting position. Right now, we're going to do at standing position. Okay, please stand up. Right. So please show me front direction.
Okey. Tengok adik go tu logi dia minyak masuk.
Okay.
Minyak bekat wanita.
Left. Thank you.
Ambil daripada bumi.
Okay, to recap, we start with static position, sitting position, okay, with support, because some of patients sometimes, if you start in standing position, they will lose balance, okay? Then we go to static, but standing posture, right? Then this is the next stage. Sorry, static standing. Okay, so this when we finish that, we're going to do a dynamic standing position. Okay, so look at the video. Okay, after we finish doing in sitting and static standing position, right now we're going to move based on 4 orientation. So we may start with bringing the client towards any wall as their landmark. Okay, Afia, identify your landmark in front of you. Raise your hand. Okay, now bring it down. Okay, now, okay, so in this particular dynamic standing position, the patient will turn according to the 4 basic orientation, front, right, left, and back, and come back again to the front. Turn to the right. Okay. Okay, turn to the front. Turn to the left. Turn to the front. Okay. Turn backward. Okay, turn to the front. Okay, check your orientation, your landmark. Okay, good. Okay, after we finish doing, so that's it, right? Okay, other than that, we use a dynamic clock face orientation. This is this is another stage after the basic 4. So basically, the patient in a sitting position, okay, will stand in the center, and you have to explain to the patient that they need to imagine that they are at the center of the clock face. All right, so in front is 12 o'clock, behind is 6, on the right is 3 o'clock, and on the left is 9. and vice versa lah, 1, 2, 4, 5, and so on. Okay, so what we do is I'm going to, for example, go at number 8, and I will make some sound. Okay, the patient need to identify that the sound is from 8 o'clock direction. So whether he or she can orientate based on sound, based on sound towards that particular numbers. Okay, once they can identify that, okay, the second stage, you can ask again and ask them to turn their body towards the number. Okay, you may start with, for them just to listen, static, do not turn their body. Okay, you can go from you can start from 12 and randomly. Okay, so depend on your client. So that this is where we will look into the cognitive aspect and of the patient, because patient with cognitive issue, sometimes they have a difficulty to identify their body and to identify the direction of the sound. Okay, so make it difficult for them later on in performing activities of daily living or orientation and mobility training. Okay. Okay, so after we've done that, okay, now we get into the action lah. Okay, so activities of daily living. So the first part is about shower. Okay, it's about shower. Okay, so what we're going to do in terms of orientation, usually I will provide a tactile plan. Usually you use this, what you call it, a tactile map or tactile picture. Usually the special school teacher. For example, if you want to teach mathematics or geography or science, okay, you make that tactile map or tactile picture. So for us, okay, to orientate the patient, okay, usually we will do that. Basically, we will it is composed of layout of the floor plan of the bathroom. So that before the patient enter the bathroom, okay, he or she will use their hand and they will identify the design of the room based on this tactile map. Okay, after that, we will bring the patient inside the toilet. We will do the room familiarization with them. Okay, and that's all for the orientation. And for the basic object for the shower, usually wash basin, a tap, a shower tap, soap, towel rack, all these things we will orientate to the patient, meaning that they have to they have to touch the towel, they have to touch the shower tap, and they have to manipulate the tap. So how to turn it on, how to turn it off. Okay, so after that orientation, and then we go into part where the patient getting a shower lah. Okay, so based on my experience, for the adult patient, there's not much challenge, because usually they are normal people, and they get maybe a visual impairment at late 30 or late 40, something like that. So they have already seen with their eyes what is the shower process is actually is all about. Okay, for the patient with congenital from congenital condition, some of them still experience difficulty at the age of 13 and 14. Okay, this is patient that we receive for the referral. Okay, so sometimes they do get a shower, but they do not apply the soap. They do not rub accordingly. So at the crease of their body, especially at this particular part area or the crease area, okay, they will have some residual. So when they go on a Monday, okay, when they go into the class, usually this particular student do not smell that good, okay, and sometimes it create problems within a peers, because we call it a mandi kerbau in Malay, meaning the person is taking a shower but do not use maybe the shampoo or do not rub accordingly. Okay, right. So if we look here, this is an example lah. Okay, so this is the floor plan. Okay, and the tactile floor. Basically, it is not the same. I just put the picture so just to make it as an example. So the floor plan should be different lah, according to the picture on the left. Okay. All right. So that's it for showering. Okay. So anything else? Right. Dressing. Dressing, we have lots of issue. We have lots of issue, starting with clothing, wardrobe arrangement, and dressing itself. Right. Okay, so the first thing what we need to do is we need to look into how to identify the color of the certain shirt, t-shirt, or any of their clothing, right? So based on my reading and what we have been practiced, usually we will use this kind of button, okay, and we sew up at the certain particular part of the shirt. Okay, I'll show you. Right. So, for example, this is one of the shirt. Okay. So you can use end of this edge. Okay. Okay. You can mark with a certain button. Okay. To give a cue that this is representing what color. Okay. Sometimes they also do at the neck area. Okay, at the neck area or under the labeling. So where you want to put, okay, you can discuss with the student or the client. The issue is to understand and to remember the marking and what it represent with. Okay, so what we did after we managed to do this, we talked to the teachers, and because the teachers, they have skill to write down the notes in a braille. So we make a simple note, okay, maybe the size of this, okay, with a braille environment, and we code with the same button so that the student can remember. So if it is a round button, okay, that is maybe yellow or blue or something like that. Okay, right. Other than that, the other issue is storage, because sometimes they tend to jumble up the clean clothing and the dirty one. All right, so this is we have to do the arrangement for the wardrobe. So where are the place that they're going to put all the t-shirt? All right. Okay. So basically, this is our recommendation based on experience after managing some of the issues at the school, right? So the school uniform should be in one particular area. Other everyday clothing for maybe for a co-curriculum, for running or something like that, for uniform, okay, should be in compartment 1 or compartment 2. Okay, wallet and all the small accessories should be in this particular area, okay, with the lock. Okay, personal items, maybe something for hygiene, deodorant, or what you call that, perfume, okay, can put under this particular compartment. The dirty clothing, okay, with we provide a bucket so that everything is put inside. Okay, so back to this. So this is actually this is actually the client wardrobe. Okay, so it is jumbled up. So sometimes you have to do the custom made divider, especially at the hanging clothing. Okay, so one of the student, basically this is actually the underwear. You put underwear actually inside there, just behind there. But because of they do not have additional plastic and so on, so she just put the hanger, and this itself she hangs to divided the hanging area. So maybe from this particular area towards this is the school the school uniform. Okay, other than that maybe a clothing or shirt for function or something like that. Okay, and we have to do all the arrangement back inside here, okay, according to the slide that we looked into before. Okay, right, so dressing, of course, you do the orientation. Okay, we prefer to use this approach, hand under the hand support, or sometimes we go behind the student. Okay, it is in order to guide the student hands in a natural pattern. All right, so everyday shirt, sometimes for the design of the shirt, you need some particular skill. Sometimes you have to be able to do the what we call it a hand manipulation, whereby you have a combination of pinch, lateral pinch, tripod pinch, especially in donning the zip or pushing the button and so on. Okay, so sometimes we do that simulation with other activity first. So after maybe a few repetition of do the button manipulation and so on, then we bring that skill towards on how to apply it at the real clothing lah. Okay, right, so we have one video here regarding ADL dressing, hand under the hand, right?
So what we're going to be doing in this series of little vignettes is help us really look harder at how we help when people may not want a little assistance getting their clothing, their outer clothing on, or another layer of clothing on because of the weather. And then we may work on getting them back off. That can also be a challenge. So typically what happens when somebody wants to help somebody put on a jacket is we start off by having them try to get their arm in, and if they can close their hand up, as Amanda just did, less of an issue. And then we have another place where we can run into trouble though, even then, where we bring it up around, and now we're asking this person to reach up near their face and to stick their arm through a hole, and whoa, hang on, don't push yet, wait. And so what ends up happening very frequently is in the underarm area of whatever piece of clothing you're trying to get on, you end up with ripped up seams, or the person gets upset and frustrated. So what we're gonna do is try something a little different. This is a very different use of hand under hand, but what the care partner does is slip their hand through the sleeve, bring it through, and now simply offer the person handshake, hand under hand, and then slide the sleeve on so that their hand holds onto yours as you bring it through and you don't catch fingers, but you also can slip it into place. Then what we're going to do is drop it down to the elbow, because it is much easier, Amanda, lean up a little bit, there we go, to bring this around and go low, because now, Amanda, what I can do is guide Amanda's hand, if she has full ability to use her arm and use her hand, and just help her bring it up in place. Or if she needs a little more help on this side, because her fingers get stuck again, keep this down below the elbow. That's the trick, because we want the person to bring their arm back just a little bit. And that movement typically is an easier movement than this movement. And it also doesn't stress the cloth. Then what I'm going to do is do the same thing I did on the other side. Bring my hand through, hand under hand, slip her arm back. She just follows my movement. Bring her hand up, and then bring the clothing up. Seems so simple, it's hard to imagine that we don't think of these things. But when we're used to putting our own clothes on, we can bring it up and over. And
Okay, that's all. Right. The other issues that we look into is ironing. Okay, basically in ironing, there are 3 tips that usually we use in training. First, the orientation. Orientation means the location of the iron, the location of the board, and the pathway of the electrical wires. Okay, so this is need to be oriented thoroughly so that the patient or the client or the students understand and know exactly where is the wire itself. The number 2 is to do the tactile sticker or at the knob. Okay, at the knob, so that they can know when they turn the knob, the heating is at what level. Okay, usually we will mark the most common one, Okay, and thirdly, we do lots and lots of simulation. Okay, we do a lot of simulation. So sometimes up to 10, maybe 15 sessions, because this is quite serious activity. Patient might burn or harm themselves if they do not doing it correctly. Okay, so this is the video. Okay, basically this is the video that I used to share with my patient, and our training is based on this.
Clothing care is an important life skill that may be overlooked when young people with a visual impairment are growing up. In this video, a visually impaired pupil demonstrates how to iron safely. It is important to add that this video demonstrates ironing based on using only the equipment most people have at home, on holiday, or at university. You may also want to practice first with a cold iron. If you iron with your left hand, the board should be positioned with the plate to the left, while the flex or cord is plugged in behind you. Place the iron onto the plate and then trail along the cord to the plug. With switch off, plug in the iron, then switch on. When positioning clothing on the ironing board, make sure that the part that you wish to iron first is closest to you. With thumbs together, place hands flat in the middle of the garment. Smooth out to the side. This has two functions. One, it helps to smooth out your garment so you're not ironing in more wrinkles. And two, hands act as a guide. The garment is hot where you have ironed and cold, indicating the areas which still require ironing. This process also acts as a guide to indicate the size, the width, and depth of your garment. When ready to iron, trail along the cord with your hand to locate the handle of the iron. This prevents a visually impaired person from accidentally placing the hand on the iron's hot plate. Iron the garment using small strokes moving from one side to the other. While ironing, the other hand is used as a guide to secure your garment, but always be aware of the distance of the free hand to the heat of the iron. When one area is ironed, place the iron on plate by locating it with your hand or positioning the iron with front tilted up and placing it on plate, then moving it back and forth gently so that you can feel when it is rested securely.
Okay, that's all.
Clothing care is
Right, so this is maybe the we are near end of my presentation. So activities of daily living, feeding. All right. So usually we use a clock reference system, which is to point and to place the plate and all others accessories usually when you use during eating. Okay, so the main plate usually is directly in front of you. The arrangement is a range of 12 o'clock. Okay, a plate of fruits may be the range between 1 or 2 o'clock. Okay, sometimes some people prefer to be at 3 o'clock. Okay, so it is easier to identify and to reach out. Right, so this is the dessert. So the dessert is at the range of 10 to 11, and this is the plastic mug. It is still at the range of 12 o'clock, but it is in front of the plate. Okay, so by doing this, it is make easier for the client to be independent with regard that he had already have the orientation of the placement of the plates and other item. Okay, so this is the summary. So we look into the basic technique. All right, so other than arrangement of the plating, we can also use the clock reference system in the placement of the food item. Okay, usually if we look into this, the nasi or the rice is actually in the valuation of 12 or 6 o'clock, which is the nearest of you. Okay, then after the rice is still in the range of 12 o'clock is the chicken. Okay, and at the range of 10 to 11, the sambal or the curry, and at the range of 1 to 2 o'clock, maybe some anchovies and boiled egg. Okay, so the clock reference system you can use in into meaningful ways. One is to plate the item, the food inside your plate, so you have the orientation. Okay, when the hand goes down, okay, you know where is the rice, where is the location of the chicken, and so on. Other than that, in terms of a broader area, okay, you can identify the location of the plate, whether it is a fruit or or maybe some kind of a sweet or something like that. Okay, right. So that is the whole sum of feeding. So this is the basics, what you need to do if, let's say, the patient or having a problem in in identifying the item for feeding. So sometimes we go very basics, all right, based on experience. So this is actually a spoon, okay. So we ask the patient basically to identify the spoon and to feel it from the body of the spoon, the neck, and the cup itself. Okay, I'm going to skip this one, but you're going to have it in part of the copy. Okay, Miss Afia. Okay, so this is mark. Okay, orientation to the mark. Okay, Miss Afia, please reach out mark in front of you at 12 o'clock direction. Okay, identify the handle. Okay, then you start from there to orientate, okay, the design of the mark. Okay, so do you feel the weight?
Yes.
Is it heavy?
A little bit.
All right, are you comfortable with it?
Yes.
Okay, so this is the plate. In front of you, 12 o'clock direction, we have a plate. Okay, please orientate yourself with the plate. Okay, use your left hand to mark, right, the starting point. Okay, and you may trail the plate. Right. Okay, now lift the plate. Okay, or not too much. Okay, turn it around, turn it back. Okay, so do you feel the weight of the plate?
Yes.
Okay, is it heavy?
A little.
Right. Okay, thank you. So basically yang ni ialah asas kepada yang macam kalau kita tengok dalam video tadi tu, dia dah ada dengan makanan apa semua. So pada forgot, it is supposed to be in English, sorry. Okay, so if you remember the previous slide, okay, it is in arrangement with all the food items. Okay, for the basic training, after we do the orientation for every particular item, right, then we will set up a plate and all other accessories like this. Okay, the client will be asked to identify the location of the plate, okay, the location of the bowl for dessert, and the location of the mug for the water. Basically, this one we use 12. This is the plate is on 12 o'clock. This is around 10 o'clock. This is around 2 to 3 o'clock, right? Okay, so this one again with some of food items. Okay, so let's have a look. Okay, now we have a proper setup for demonstration. We have fried rice. Okay, we have some dessert and we have some water. So Miss Afia, you may start to eat. Okay. Okay, identify the spoon position. Right. So how is the taste?
Spicy.
Okay, now we have option. Okay, inside the bowl. Yes, you have to peel off the wrapping. So how is the taste?
Sweet.
Sweet. Okay, so now you have oriented towards all the position of the items that you need to use for the session, right?
Yes.
Okay, so can we recap before we go on? Okay, so the position of the main plate. Okay, can you tell me where is the position?
12 o'clock in front of me.
Okay, what about the mug for the water?
The mug is right beside me at 3 o'clock.
At about 3 o'clock.
Yes.
Alright. Okay, what about the dessert position?
The dessert is at 9 o'clock, my left beside me.
Alright, okay. Thank you. Sometimes,
Mr. Wafi, sorry to interrupt. You have 5 more minutes, yeah?
Alamak.
Thank you.
Alright. Okay, so we finish. Okay, so this is the last one. Okay, activities of the living, functional mobility. Right. So functional mobility. So I go straight into the slide lah. Right. So it is defined as a movement. Okay, for you to move from one place to another. Interesting part with regard to visual impairment, it is also considered as or defined as the ability to negotiate of any obstacle and hazard. So rather than a conventional definition, which is just to move around, okay, being an individual with visual impairment, you have to learn and achieve the orientation and mobility skill so that you can negotiate any obstacle, right? So in this particular functional mobility, all right, there are 4 main items that we use to train patients. Okay, we train them to identify the landmark, the clues. If let's say we do the mobility inside the building, the additional item is indoor numbering and compass direction. Compass direction is basically with regard to the basic 4 and the clock space. All right. Okay. Landmark is basically the main marker used to identify the location. Usually, landmark is something that static and cannot be moved around, right? Okay, clues. Sometimes clue is kind of element that complement landmark in a pathway, but clue, one of the criteria, it is do not static. It can be moved. For example, if you have I give you a situation from your house, okay, from the gate, okay, you want to go towards maybe a mamak stall. So from the gate itself is considered landmark, and mamak stall, of course, a landmark. But in a way, okay, maybe you have a garbage dump. So garbage dump considered as a clue because every time you pass around, okay, then you will smell that uneasy smell from the garbage dump. But the dump can be removed. Okay, maybe it can be located somewhere else. So the landmark is from the gate of your house towards the mamak stall. Okay, the smell itself is considered as a clue. It is just to complement. So every time you move around, then you know that, oh, okay, when I smell this, maybe I'm about halfway towards the mamak stall, right? All right, orientation and mobility training, teach people to use their remaining vision and other senses to get around. Okay, so O&M, there are quite a number of techniques inside there. All right, there are quite a number of techniques. So this is a part of parcel of the intervention that we use to teach our patient. If we get referral from a school, usually the training will be around the school compound. If we get the referral from a clinic, then we can go. We can choose a different site. Okay, to expose the patient towards a different gradient, different plane, so that it can enhance their skill. Okay, so what we do actually in a functional mobility, okay, introduction to the long cane or wide cane, okay, and then stages of learning how to use the cane, how to wheel, how to handle, and then the technique itself, diagonal techniques. This is usually part of an indoor technique. Touch technique. Touch technique usually touch technique is divided into 7 particular subspecialty. 2 of them are straight line, and touch and slide is usually used inside the building. The other 5 is a 2-point touch, touch and drag, 3-point touch, modified touch and drag, and modified touch and sliding. So this one, this another 5, usually we will train our patient and use it at the outdoor travel. Okay, the rest is for indoor travel. Clearance for obstacle and how to negotiate, contacting object. Okay, negotiating doors, negotiating stairs. Okay, so how to get up stairs if you have a white cane, or if you have a loan, how to secure your flanks when you move around, and of course the part of it is a human guide with cane. Human guide is a term that being favored by Lil Deborah. She is the founder of new framework for orientation and mobility. I used to use the cited guide. Okay, cited guide is from the 1957 what you call that, guideline book. Okay, it's still being used around massively. So for us, we use both techniques, cited guide, okay, human guide, okay. So it depends on the client preference, and sometimes people with cited guide experience, they prefer to use that technique. So we can use that. But if the new patient, sometimes we can use human guide. Otherwise, we look into what is the needs of the patient. That is always our priority. All right, so okay, so this is part of the mobility training. Okay, this is how to cross the road, and this is my teacher lah, Cikgu Nur Zailan.
Jalan, dia berada di mana? Guide? Ini ataupun ini. Okey. Masa saya melintas, dia mesti berada di mana? Di belakang ataupun di sini. Tetapi bukan di sini.
Kalau kata kereta ke arah sana, dia tak boleh berani kat sana lah.
Ya. Tapi kita tu dari sana. Kita dari sana. Kereta tu dari sana.
Dia tengok.
Dia semua tak boleh menghalang kereta dari sana.
Permulaan tu kita kena tengok apa yang kita rasakan dulu lah, jalan dari sana.
Sebab sebelum dia lintas, kereta dari sana dah nampak. Sama juga kalau dari sini. Kalau dari sini. Sebelum impart, dia berada di sini ataupun di sini kan. Bila dia mula melintas, dia berada di mana? Belakang ataupun di sebelah sini. Bukan di sini.
Right. So basically, this video is to show you the the range of training that we provide to our patient. This is for crossing the road, and for your information, this is active road. Unfortunately, during the theoretical session with Cik Zailan, there's no single car come around. When we start to take over, then there's not only car, there's a car, there's a lorry, there's a motorcycle, you know, petrol car as well. So it's very interesting, right? So for this particular setup, basically, this is a part of the what we call it final drop off for the student. So basically, they have to travel for around almost about 7 kilometers. They started to walk from the faculty until this is Chowkit monorail station. Okay, they going up to the monorail station. They buy the tickets and they ride the monorail until a certain place, and then they have to go down and eat at one of the mamak stall, and they have to turn back. All must be done in blindfold. Okay, so that so that is the training. So what happened is when they the beauty of this training is that when we have a client and when they start to treating a patient or training the student, they have a patient inside them because they themselves had experienced the difficulty itself. So I think with that I conclude my session, and thank you very much. I sincerely hope that what I've been sharing with you will be useful for you as additional knowledge. Thank you.